right, so easy landmarks, greater trochanter right here. You're going to have to be using this when we do the knee too. So you're going to hear these measurements again. And you know what, while we're here, we're going to do the knee also. So greater trochanter for the hip is going to be your axis. Your stationary arm is going to be midline of the trunk, and the movable will be midline of the femur to the lateral epicondyle. And when we do the knee, the lateral epicondyle will be your axis. The greater trochanter will be your stationary arm, and the lateral malleolus will be your movable arm. So, and I'm going to kind of show you this because in the clinic you usually don't do one joint and then, you know, flip them around, do another joint and back and forth. Usually it's like if you're on one side, you're going to measure everything going down. Okay, so what we're going to do is make sure I've got this right side up. We're going to put it here on the grid. And just for reference, most of you have pockets. If you stand up, the greater trochanter, find the bottom of your pocket and come up, and that thing, that little bone that sticks out there, that's your greater trochanter. The easiest way to find the lateral epicondyle of the knee is go superior to the patella on the lateral side, push in until you feel that there's very little between you and bone. Okay, that's the lateral epicondyle. So hopefully you know where the midline of the trunk is. All right, midline of the trunk here. Bend up for me as far as you can. All right, so what we're going to do is we'll get our measurement there. Okay, and back down. And we have, she has 118 degrees of hip flexion. So the reference angle is 0. Don't worry about starting at 0 and following it through. Measure the end point, know where you started so you know where you're reading your goniometer from. So that would be hip flexion. While we're in the neighborhood, let's do knee flexion. So we're going to go axis, lateral epicondyle of the femur. Stationary arm is along the midline of the femur to the greater trochanter, and the movable arm will be down here to the lateral malleolus. Bend your knee up as far as you can for me. Okay. And then we can get a measurement there.
Arms, right?
What's that?
It's the wrong arms. On each of the stationary is along.
I think he doesn't mind which one is which as long as
This doesn't know which arm is which. You tell it. Okay, it's a dumb goniometer. It's not a smart goniometer.
Okay.
Yeah. You tell it by where you line it, and basically so you can see the numbers right side up. All right, so she has 135 as far as her knee flexion. She's extremely normal. 135 to 150 is the normal range. I didn't look up the normal range for the hip, but I'm pretty sure she's normal too. There. So that's flexion of both of those. The way I'm doing it, used to doing it with Norkin and White, but this is the way they show it in Clarkson. Put your leg down, and we're going to put this, put your leg up just a little bit. Okay, down. All right. And now what they are going to do is have you actively extend, and same axis, lateral epicondyle, greater trochanter, lateral malleolus, and you can see that she is going a little bit past that mythical 0 line, and she is going past it by 3 degrees, and relax. So what I would say is that's 3 degrees of hyperextension at the knee. Okay, if it does not reach 0, I usually note the degrees from 0. So if she was 3 degrees before she reached 0, the way I note it is lacking 3 degrees of full extension. Okay, so 0 is the mythical extension, just kind of like what you did in the elbow. Some people went past it, some people went to it, and some people didn't quite go there. So you have to tell us if you're getting 3 degrees, whether that is short of 0 or hyperextension, which would mean it went past 0. Okay, so before we get to extensions of the hip, while we're in supine, why don't we just bang, 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 measure that hip flexion, knee extension. Okay, so you will need a towel, and it goes underneath the thigh so that the knee is free, and you want to make sure that if it's active extension, and that's so that they can come off the table a little bit, because if we didn't have this here, go ahead. All right, see, she's resting on the table, we can't really get a true measurement. Okay, all right, so go measure. All right, so you want to have, now you have to scoot down a little bit more. And it might even be too big of a bolster now, but we'll deal with it. Okay. This position here, and we have a high-low table. Sorry, those who are filming, I'm moving in now. You can get it up so you can get good body mechanics. Now, when we do practicals, I have this room, and I always go back there. There's a high-low table. Make sure you know how to use one of those so that you don't get marked out for body mechanics. What you're going to do is you're going to measure plantar flexion is down, dorsiflexion is up. Mythical neutral is at 90 degrees. So know if you're going to use your small goniometer. So if you take your small goniometers out and you turn them to 90 degrees, you also notice it points to 0 on the red line. So you're going to use the inside numbers. Okay, and again, you don't really want to follow these motions because they're going to be tough to follow if you come from 0, do that. So you want to go to measure the end point of motion. So we're going to do plantar flexion first. Axis is going to be the distal tip of the lateral malleolus, stationary arm to the fibular head, and this is very important, movable arm parallel with the sole of the foot. So we're going to put it here, line it up to here, and then this goes parallel, not to the sole of the foot, but parallel to the sole of the foot. Okay, and then you can read your motions as far as you can point. Okay, good.
Down? No, I can go. I didn't know I was supposed
You can
to
go. Okay, can you go farther?
Yeah.
Push. There we go. I was going to say that didn't look. All right, so parallel with the sole of the foot. Pull it away, and here's a problem that you're going to run into is that she went past the end of the red numbers. So you will then have to go up and add from the black numbers where she was. So we went past 50, so I would say she's about 62 degrees. Okay, don't be reading the opposite end, which says 152. Okay, that's really not possible unless your foot goes around backwards. So dorsiflexion would be pull your ankle up towards you as far as you can. And again, same landmarks, distal fibula or lateral malleolus, head of the fibula, parallel with the sole of the foot, and relax. And she has there on the red scale about 8 degrees. Okay, so now we've measured that. You simply have to Clarkson on page 361 would have you doing this with the patient sitting, knee flexed to 90 degrees, but that would mean I'd have to put this up in the air and probably sit down on the ground to get in line with my goniometer. Here it's really easy. I'm right here. So the only thing you're going to have to do is note this is an alternative position, state the position. Okay, she's in long sitting with a bolster under the knee. If we really wanted to be precise, we could actually measure the flexion angle that knee was in when we did it. The foot has to be clear of the table so it doesn't bind the motion. So inversion is turning the foot in, eversion is turning the foot out. Now the only thing that you have to do is kind of take your thumb on the metatarsal heads and make sure you are getting pure cardinal plane motion, inversion going in, eversion going out, because Most of us, if we tried to turn in our foot as hard as we could, we're going to get some subtalar motion, which is supination, and see how the foot curls in. And if we really try to go out, we're going to get a little bit of dorsiflexion and pronation with that. So we want to make sure it's that in-out motion that's coming from the talocrural joint. Okay, we don't want to measure subtalar motion. We are not going to measure pronation, supination. That's a subtalar motion. It's called a rear foot motion. We've decided, and even Dr. McCarthy's in agreement, we don't need to measure that. Okay, unless you can get into sports medicine and then ask a PT to do it. Okay, so the axis will be the mid-malleolar point. So find the malleoli. Your axis is going to go in between it. You're going to go midline of the tibia to the tibial tuberosity and parallel with the second metatarsal. Okay, so it's similar to kind of ulnar radial deviation. So again, what is folly, and since you're filming this, is this does align up at 0, so you'll be reading the black numbers in and out. And the reason that you have to use the small ones here, you could actually use a large one here and get away with it, but you have to kind of contour this one, and the large ones are too rigid. They would not contour. They'd snap if you put them on. But do not try to start from 0 and follow the motion, because she'll be filming this, so she'll see what happens. Right now my axis is right in between the malleoli, but go ahead and turn your foot in as far as you can. Okay, and now if I were to measure her, my axis starts riding out toward the lateral malleoli, and go ahead and turn your ankle out as far as you can. And if I did that, then my axis starts riding out toward the medial malleoli. So what you want to do is go ahead and turn in, is have them go to that end point of motion. You got a nice flexible goniometer. Get it right in the midpoint. You can see right over it. Parallel, let's get the supination out of there. Parallel with the second metatarsal. You won't be right on it. You'll be parallel to it. And then you can get your reading. Relax. She has 40 degrees of inversion. All right, turn out for me. And you have to make, the only thing you want to make sure is that they're not rotating their hip, and there is tibial, external tibial rotation that can occur. So just kind of make sure that you've stabilized that, that area. When you do that, you come down, and here's your stationary mark parallel with the second metatarsal, and she has 16 degrees here. So you're going to have a little less eversion than inversion from that neutral point. But then we didn't have to change positions. So clinically, we in supine, we measured hip flexion, knee flexion extension, put a bolster under here, hang the foot off, come around, bang, bang, plantar flexion, inversion, eversion, and we've done all the joints. We have to go back up and catch what we missed, but instead of hopping around, we're just going to be in one fluid motion. All right, so for those of you who are on a stationary table, you may have to kneel down to get your measurements. Okay, yes.
For sake of practical in our video, if we have that ankle plantar dorsiflexion, do you want us to state what the knee is at? No. Okay, because you mentioned that, so I wasn't sure.
No, I said if you really wanted to be precise, because here's the thing. If we just did, we might get different readings if we didn't have a bolster. And there's bolsters, if you notice, I brought the smaller bolsters. There's bigger bolsters over there. So, all right, so let's see if it does make a difference, especially with dorsiflexion. Pull up as far as you can. So I'm going to measure that dorsiflexion, and it didn't. Okay, make a big difference. I got 8 degrees still. Point down. Okay, and I got a little bit more plantar flexion. Actually, I've got 65 degrees of plantar flexion. So it makes a little bit of difference. But somebody who had some real Achilles tightness, it probably would make a difference because the knee is relatively straighter here than it was before. So for me, I would just say you placed a bolster under the knee for your video, that's going to be good enough. But in the clinic, it wouldn't hurt. Okay, so for the video, here's what I want. You're going to place a bolster under the knee. Pre-measure that. Don't measure it during your video. Say, I've pre-measured that knee angle at X degrees flexion. Because when you go to a clinic, if you just said, I put a bolster under the knee, did you use a small bolster? Did you use a large bolster? Did you use a rolled up towel? What did you use? Some people will have coffee cans. Some people will have 6-inch PVC pipe from the hardware store. So a bolster is not a bolster is not a bolster. They're all bolsters, but they angle the knee differently. So to be reproducible, you should state what that knee angle was. Okay? So if you get that for your video, you can pre-measure it and say, I'm going to put a bolster under knee. I've pre-measured that angle of flexion as X. Boom. You're done. Okay? All right. Okay, so when you're doing this, easy landmarks, again, you're going to find the ASIS, okay, that thing that sticks right out here on the front of the pelvis. And where her clip is, there's the other one. So you need to locate both of them. Your axis is going to be, it says in Clarkson, same side, ASIS. You've taken anatomy from me. I'd like you to say ipsilateral ASIS, okay? So you're going to go on the ipsilateral ASIS. Your stationary arm goes across the ASIS. And then the movable arm is midline to the femur, and the patella is your distal reference point. Can you scoot over there just a little bit? Okay. All right, so we're going to find those spots again, put it here. And so know that your goniometer is starting out, your anatomical reference position is the 90-degree position. So you're going to be taking your readings off the red numbers, but you don't have to start from 0 and have them measure the endpoints. If most people can stand with their legs straight up and down, they're probably going to be at 0. So what I'd like you to do is move your leg out to the side as far as you can now. See what she's doing? We're getting an awful lot of lateral rotation. So the key is toes up, cardinal plane motion. So go out as far as you can with your toes up. And when she starts to rotate, that's the end of the motion. Okay? So then you would just go like that and take your reading, and she has 43 degrees of abduction. Now to get adduction, scoot over toward me. What you're going to have to do is abduct this one out of the way as far as you can. Okay, so now we have room to adduct. So what I'd like you to do is, again, toes up and come over as far as you can. Okay, without twisting your foot, toes up. Okay, no medial rotation. So you've got to watch for those rotations. And there, see how you can't just kind of point the thing straight across, because now her ASIS is way up here. So here's across the ASIS, ipsilateral ASIS, midline of the thigh to the distal landmark of the patella. And I'm going to pick this up here, and she has 12 degrees. It looks like she has more, but look at how high the other side is. Okay, so she has 12 degrees of adduction. She had 43 degrees of abduction, and you just repeat for the other side. So landmarks are the same. You just have to make sure that you give, and you could appreciate if you were on a regular size plinth how tough it would be to get this measurement, because your legs would be hanging off. So you got to use a mat table, or if you're in a clinic, push 2 plinths together so you've got room to have the legs supported. Okay, so we'll do that. Against the wall, and you're like this, you're basically prone, only in standing. Okay, so you can have your patient. So that will be a fine alternative position for me. Just state that it's an alternative, than prone. If you happen to be working with athletes who are swimmers, then prone is the perfect position, because that's the position that they're in and they need to function. So know that the book is that, and if you want to do it at home and lie down on a table in prone, that's fine. But you know that a lot of the elderly clients you're going to be working with are not going to be able to lie prone. It might even be contraindicated. That doesn't mean you can't take a meaningful measure. So measure it quickly, prone, and then go and measure it standing. You will find there are slight differences, and that's why you have to state the position you measure it in. So same landmarks as we did for hip flexion, but we're going to do this prone, then go stand up against the wall, measure it there. And the things that you have to watch for when you're when they're up against the walls, you want them to say stay glued to the wall and do this. Don't do this and push away from the wall. You will get, as you start to flex the trunk, you will get a different measurement. So let's measure both.
Yeah, go back. Toward the lateral epicondyle. I can try both sides.
I'm scared for it.
Yep.
Yeah. Like that?
3 degrees. The only thing that can be confusing about rotations is they're a little counterintuitive to what we do when we're standing. So what I'd like you to do is I'll take your right foot, internally rotate it from the hip as far as you can. Now flex your knee, and where does your leg end up? Out to the side. So when we are measuring in sitting, it's counterintuitive. This is internal rotation, but you're going out. And this is external or lateral rotation, but you're going in because you're sitting with your knee in hip flex 90-90. So when we're standing, if we laterally rotate, our foot goes out. But if I start to bend that knee up, it comes across toward the midline. So that sometimes it can be confusing in a practical. You'll be saying, I'm measuring internal rotation. I'll be like, really? That's nice. Okay. Or opposite that. So I need a victim to have a seat. Here, I am going to, and you can do that. We can probably fit 3 to a high-low table. So I'm going to have you do that because you're not going to have room to do this here. What we're going to do is we're going to put a towel here, similar to what we did in the shoulder, just to level the femur. And then you're going to use your large goniometer, and your axis is going to be on the midpoint of the patella. Okay, so midpoint of the patella. The stationary arm is perpendicular to the floor, and then our movable arm will be anterior midline of the tibia. So what you have to do is make sure that when they go out, they're not going to be able. When you do these, you're not going to be able. Even you as normals are not going to be able to hold this position long. So don't sit there and try to take forever to get your measurement. Get it, squeeze it, and then let them come back to resting position. So what I'd like you to do is I'd like you to turn your foot out as far as you can there. Okay, we're getting a little abduction, so make sure you stabilize that. So here we go. We're going to measure here and here. So this is perpendicular to the floor, midpoint of the patella. Okay, come back to rest. All right, and then we're going to read that, from the 0 point, he moved 10, 20, 35 degrees, okay? And that was which rotation? Internal. Okay. So now we want to come and pull your foot in as far as you can and keep your leg. They're gonna want to flex a little bit, so you wanna make sure we keep that flat. Let's get that measurement quickly here. Okay, and relax. And he has 22 degrees of lateral rotation. So you can do internal external on both legs. Just switch the towel, boom, boom, you're seated. You've got, if they're up on a high-low table, you're down on a stool, you've got a good alignment. But while you're here, we're going to start jumping right into right here, we could remove this. Can you take your knee and just raise it up toward the ceiling for me? Great. Bring it back down, raise it up again, hold it there, don't let me push it down. 1, 2, 3, 4, 5. I've done 3, 4, and 5 for hip flexion. Now the Sartorius, what you're going to do is, just like you were going to cross your legs, I want you to bring your heel up towards your opposite knee, okay? But know that this motion is hip flexion, abduction, lateral rotation, and knee flexion, okay? So when we resist that, we have to try to push the hip into extension, adduct it, and extend it, and internally rotate it. So, ready? So, I'm going to simplify it for you. Force couple, okay? So the force couple, proximal hand on the distal lateral leg, resistance hand down here on the medial distal lower leg. And you're going to do this. Ready? Hold. 1, 2, 3. Okay? So then the alternative position, which we'll show, would be supine. Could you do that in supine, which would be gravity reduced? Then we're going to go to hip internal external rotation. Well, guess what? If you've measured range of motion, what do you already know? If they can move against gravity or not. Okay, so we already got a range of motion measurement, so they must be at least a 3. Well, they might not be. Maybe they didn't have a lot, but let's assume they did. So if you would, turn your leg out, hold it there, don't let me pull it in. 1, 2, 3, and come out here. Don't let me push you down. Hold. 1, 2, 3. In sitting, and then knee extension. So can you take and straighten your leg all the way out? We're jumping down to the knee now, but we can still do it in sitting. So that would be extension. What I'm going to do here, you don't want to stabilize here because you're over the quads. So what we're going to have to do is grab underneath, hold there, don't let me push you down. 1, 2, 3. So he is a 5. And then our alternative position would be sideline. We'll go into the alternative positions, but while you're here measuring internal external rotation, let's just go bang, bang, bang through all the muscles we can do in sitting. Okay, they're all up there for you. But what I would do is, since we have a bunch of you, let's try to get at least 3 to a table adjusted up so that you can be, or if you can pull them away, you might even have some people on the front side and the back side. Just don't bust the table. Okay. All right, so let's go. All the things we could do in sitting for normal grade. So let me have victim here who can sideline for me. Oh, come on. Sideline and head up this way, feet down that way. Okay, and actually flip over the other way. Okay, so let's take a look at what we did. Hip flexion. Okay, so hip flexion. We were sitting and we had to bend up. So here, what we're doing for 2 and sideline is we're mimicking what we did in sitting. We had our knee bent to 90 degrees. You're supporting the leg, and then they would come this way here, and you are not assisting them, you are supporting the leg. Can you bend your leg up for me? Okay, so I am not moving it, I'm supporting it. The biggest mistake is that therapists tend to move it passively for them. If you want to show them this motion, that's fine. Say, now can you do it yourself? So we have to be starting from hip extension. Okay, can they move through that range? So that would be for the hip flexion. Now, we're right here, we can do knee extension. Remember, we were sitting and we tried to extend the knee. So here, now you're just going to move and support the lower tibia. I want to see if you can straighten your leg out for me. Can you straighten your leg out? So there we've got that for knee extension. What are the other ones here? Okay, knee extension. Okay, now flip over on your back for me. So now the Sartorius would be, you know, this is going to be gravity reduced. Can you bring your heel up towards your leg or kneecaps there? Opposite kneecap. So I'm just, again, I'm just supporting, taking some weight. I'm not doing the motion for her. All right, so that would be for the Sartorius. And now the knee internal external rotation. Again, we're going to mimic the position that they were in sitting. So 90-90, 90 degrees hip flexion, 90 degrees. Can you turn your foot out toward me? Which one is that?
Internal.
Internal. Can you turn your foot in toward your opposite leg? External. Okay. So again, I'm supporting and guiding. I'm not pushing with those. So those would be the alternative positions. But what I want to do is, so you can do those when you, now you can use your regular mat. Going to do inside lying our normal tests. We'll start with hip, ab, and adduction. So if you would flip on your side, okay, and scoot toward me just a little bit. Okay. Now the one that's, I want you to bend your bottom leg. Hip abduction. We're going to be isolating the glute minimus, glute medius. These are the ones that are weak most of the time. And people will have a lot of compensations for these. So there is a test in your book which allows it to drift forward, but then you're testing the TFL. And if they drift forward when you're doing this straight cardinal plane movement, they probably have weak glute medius. So if against, can you lift your legs straight up toward the ceiling for me? So if they can do that, but they drift into a flexed plane, that's a substitution of the TFL doing that. So that is not a normal grade for abduction. What you have to make sure is that the alignment is critical. Shoulder, hip, and ankle are all in alignment. And you may have to coach your patient a little bit. I need you to scissor your legs straight up toward the ceiling and down. Good. All right, now come there. I want you to hold it there. Don't let me push you down. Your resistance is going to be just proximal to the knee. You're going to stabilize the pelvis. Hold there for me. 1, 2, 3. And these are strong muscles. You can lean on them. Okay, and down, down. Okay. So that was for abduction. Some of the other compensations you may see is kind of what we saw when we measured abduction. You might see this, and then what they're doing is they're actually rolling not only the TFL but the rectus femoris into play to do that motion. So it has to be that the shoulder, hip, ankle are in line, and the foot stays parallel to the table. Okay, so you don't want it rolling out. You don't want it drifting forward to isolate that muscle. All right. Is a little bit more interesting in that what you have to do is, just like when we measured ab and adduction, you had to get one leg out of the way, so too with adduction. So now what we're going to have to do is get this leg out of the way. Can you straighten this bottom one out? And can you lift it, scissor it up toward your top leg? Good. Hold it, do that again. Hold it there. Let me push it down. 1, 2, 3. Now, for this one, you only have a resistance hand. You're stabilizing by body weight into the table. So you don't need to stabilize here. You need to hold the other leg up. Okay, so the stabilization is implicit from your body weight with your pelvis into the table. So all you need is a resistance hand, and again, that's going to be proximal to the knee, or on the distal femur, just proximal to the knee. Now, it came up in the other class, and you know, a lot of you are like, well, you know, why can't I have my patient do this or this? This assumes an awful lot of flexibility. If you have little old ladies, you're probably not going to be able to do that, or even little old men. This is the preferred way we want you to demonstrate that. Okay, if you're in yoga class, you know, or you can do that kind of stuff, but patients usually can't, or they wouldn't be coming to you. So that's for hip, ab, and adduction. Now, we've got her in this position. We can do this motion here, raising the foot straight up toward the ceiling. What motion is that? Eversion. Okay, so that's the peroneus longus and brevis. So can you turn your foot ankle right up toward the ceiling? Good. Now hold it there. Don't let me push you down. 1, 2, 3. So I'm stabilizing, you know, up here. Remember where the peroneus longus and brevis are running from? So you can kind of be over the knee. Don't be over the muscles. Okay, so you can be just, you know, right over the knee joint, or again, distal, you know, distal femur. We want to stabilize the knee joint when we're doing this, but we don't want to be over the muscles we're asking to convert. Now, what we can do is we're right here, and we can do this motion here straight up toward the ceiling, which would be the motion of inversion. Okay, and this is the peroneus, or excuse me, the tibialis posterior. So hold there. Don't let me push you down. 1, 2, 3. Relax. Okay. So now, if we are coming up and pulling your ankle up toward the ceiling, so we are inverting and pulling up. What muscle is that? Tibialis anterior, against gravity. This is the only thing where I want you to note, and I've starred this on page 33 or 377 in your book. It shows this as the gravity reduced position. They're wrong. Okay, this is perpendicular to the force of gravity as you're coming up this way. No matter if you're trying to bring your toe up or up and in, it is against gravity. So this is the correct against gravity position. Hold it there. Don't let me push you down. 1, 2, 3. So make sure that you know that. So we've got eversion, plane inversion, inversion with dorsiflexion, and we've done all of those. So now, if you would just turn over. We'd have her flip over the other way so we can do the other side. This way here. So this is the way. Eversion, you know, would be in supine. Can you turn your foot out? Now, if you've already measured range of motion, what do we know? It's a 3. Okay, so this is a 2, you know, or it's less than 3. Okay, so we know that they're at least a 2 if we've measured their range of motion. Can you turn your foot in? Okay, so that would be pure inversion. We've already measured that in range of motion. I've already done. Okay, and it says, I'm going to have you scoot back. So we keep going. We started off with the hip. So the hip, we would do abduction, adduction. Haven't we just measured that with range of motion? So if they can do that, we know they can do it in the gravity. That's why you do range of motion first. But if you have to demonstrate it, this is how you demonstrate it, okay? Or if you're making a video, you can say that you're doing this, and this would be the gravity reduced position for those muscles, so we know they are at least a 2. Then you got to show me if they're 3, 4, or 5. Okay, so you know, if you can make some of those clinical rationales, I'm okay with it, as long as you state it clearly in your video. Now, the only thing they say for you have to scoot forward and sit up. They say for the tibialis anterior that you're going to be sitting and you're going to kind of come up like that. Now we've kind of almost measured that with dorsiflexion and inversion. So that would be the gravity reduced for that motion there. And again, what I'm doing is I'm not forcing it over, I'm just guiding it, okay, when I'm doing that. So there's all the things you can do in side lying. So that's that next group: hip abduction, ankle inversion dorsiflexion, which is the tibialis anterior. Make sure that you note that that's going to be flip-flopped from the way they have it in Clarkson. I've discussed this with Kay. We're in agreement that side lying is truly against gravity. And then the pure inversion, pure eversion. Okay? Now, and for time's sake, I tested the right leg of eversion and the left leg inversion. Then when I flip her over the other side, I can just do the same thing. Okay? If you were just doing the, if you wanted to be a purist, you would have to do one side, then flip over, do the other side, and do them individually. But for the sake of demonstration, while you're in the neighborhood, do them both. For the gastrocs and soleus, you're going to do the alternative positioning that is described over on page, make sure I get the right page for you, 380 in your book, because that's pretty easy. You have a patient, they can support themselves for balance, or you can help support them for balance, and they're going to stand on one leg with the knees straight. Can we come up on our toes and lift our heel completely off the floor? 1 to 2 is 3, 4 to 5 is 4, and 6 is 5. Okay? Then, if you want to do the soleus, you're going to flex the knee and do the same thing. Okay? And count the same way. So that's 3, 4, 5 grading for the gastroc and soleus. Gastroc, the knee is straight. Soleus, the knee is flexed. Alternative positioning is described as side lying. Can they plantar flex? We can't assume that if we measured range of motion that that's the alternative positioning, because that's with gravity they went. So you can't use that argument there that you measured the range of motion, because it's with gravity. They may have nothing and their foot just flopped down because of gravity. So you have to actually test that. Then hip extension. In your book, it shows 2 ways: prone and inclined. Again, unless you have a swimmer or an athlete, most of the clients that you're going to be testing, you'll do in what's called the inclined position. So if you have a high-low table, you can put it up high enough. If not, you'll have to build up on some pillows. So try to use the high-low tables. Again, you can raise them up and have 2 or 3 people, as you're just going to come lean over the table, and then you are going to go and extend. That's against gravity. That would be a 3. If you put the resistance, what you want to do is you want to stabilize above the belt so that you're not over the glutes or the hamstrings. Your resistance will be on the distal part of the leg, so you can see if they can hold that position for 3, 4, 5. So let's do those. Those are quick. Trickier, so we'll do that once we get the quick and easy ones out of the way. The alternative position for hip extension would be hip side lying, and from a flexed position, can they extend? When we were in flexion, we said from an extended position, can they flex? It's just the reverse. From a flexed position, can they extend for alternative positioning? So do the quickies. Couple of ways to do this, because most of us will have a regular height plinth like in the other room, not the low tables here. So I'm going to demonstrate regular height plinth, and then we'll have to show you how you would do it on the table. Remember, just recently, the biceps, I don't know if you guys had to, if I made mine do all 3 positions. We had the biceps, brachioradialis, and brachialis, so that you could isolate each of those for 3, 4, 5, but when you did combine, you just combined them all in the alternative positioning. It's going to be the same deal for the hamstrings, as we're going to test them as an aggregate group, but we have a medial and lateral set of hamstrings, and we're going to isolate them here. Because oftentimes when somebody pulls a hamstring, very rarely do they pull the entire group. They pull one of the medial or one of the lateral group. So that's a way to isolate it. So if you're on a regular height plinth, this is a very long lever of the leg, coming up. So I'm going to show you how we can get stabilization, because the pictures will show that their pelvis is strapped to the table. Again, I've never been in a clinic that has straps, so you have to improvise. So for just the regular aggregate hamstring with the foot in neutral, can you bend your knee up toward the ceiling? Good, and back down. And then for 4, 5, I'm going to have it in the flexed position. What I'm going to do is I'm just going to lean my body over the pelvis. And now I'm going to try to push the leg down. Don't let me push it down. Hold. 1, 2, 3. So that would be, if it gave a 4, if it doesn't, a 5. Now for isolating the medial hamstrings, you would have them turn the leg in and bend up. So I want you to keep your foot turned in and bend your leg up. Good. Hold there. Don't let me push you down. 1, 2, 3. That isolates the medial hamstrings. And for the lateral hamstrings, what I want you to do is turn your foot out and bend up. Good. There's a 3. Hold there. 1, 2, 3. And if she couldn't, I would turn her side lying, and it's the opposite of knee extension. In knee extension, we have the knee flexed, and could we extend? And for the hamstrings, it's you're in extension, can you bend back? Same thing supporting the lower leg. So if you're on a mat table, you'll have to basically kind of get up on your hands and knees and do that same positioning, because you'll have to actually get on the table. If your patient's prone and you're bending over to do that, you're going to be marked off for body mechanics, because you're going to need to get on the table, have your patient get over there a little bit so that you can do that. And you do not have to then lean down like I was on that height there. You can put a hand on the pelvis and do that, so you keep your back straight when you do that. So it would look more like, let me put her down to mat. So it would be more like, you could do this, because if you're on that low mat table, there's no way you're going to be bending over and doing that. That's a little uncomfortable. Okay, so just keep your foot, just bring your foot up. Most people are not going to twist it unless you tell them. Now turn your foot in, bring it up, good, hold there. Okay, back down, bring your foot up, turn it out, hold there, don't let me push it down. And it's easy in especially in your video, if you're talking, this will help you talk through your muscles to remember them if you're going to say the groups. I'm going to test the combined knee flexors, the hamstring group. Then when you do the medial, just say this, relax. You turn the foot in, just say this isolates the semimembranosus, semitendinosus. When you're doing lateral, this isolates the biceps femoris, long and short head. Boom, you're done. Okay?